Thank you for being interested and coming back from lunch already. So I may just start off with a few pictures. And first want to acknowledge that the traditional owners of the land we are meeting, the Watcha Noongar Watcha people, that are the traditional custodian of these countries and these waters, and we would like to pay respect to the elders past, present and future, and extend this to all Aboriginal people. That is what we use in the detox unit because we have Aboriginal people and people from everywhere across the state, up to the Kimberley and everywhere. Okay. So first a few pictures. That is sort of the entrance of Next Steps down at 32 Moore Street, East Perth. We're located at the same place like our outpatient clinic. And if you have somebody that is interested in coming to the detox unit for withdrawal treatment, we have a YouTube video for clients to watch so they can get a bit of an idea how the unit looks like and what our program is like. That's on YouTube as well as on Facebook if clients want to show it. That's how the unit looked like. We had a bit of refurnishing over Christmas. So you see the first top left is our living room area. Second top right is the group room. It's quite a comprehensive group program that we're running. And the picture at the bottom is from our sort of quiet area where there is room for art and craft, for reading or a bit of quiet time. Outdoor area is really important. We try as much as possible to support our clients can't be outside. It always needs a staff presence because we're in the middle of town and there's sometimes drop-off over the fences. But we try to do groups out there as well. We try to be just out and about. And I am asked to mention that we do barbecue with the clients, and it's a big thing for the clients and a good thing. That's our meal area inside. In general, the Next Step Detox Unit is elective admissions. So we have 17 beds. They're double rooms. We have sort of like a two-legged service. One is the withdrawal treatment, medical withdrawal treatment, and the other thing is a group program, which is about education and information about all the different services and AOD supports out for clients that they could engage with after us. We have two Aboriginal health workers, a female and a male staff member, working full-time to make sure that our unit is culturally safe. They give us each year education sessions as well. We're a very multicultural team as well. Clients cannot use their mobile phone or internet. It has different aspects of it. One is that they really can concentrate on their treatment there and not being too much influenced or burdened by what's going on out in their social network. The other thing is as well about stopping maybe contact for a while with dealers or anything like that and being safe from whatever it is, TV or whatever is out there. They can purchase phone cards, they can ring out, but that's then their choice, not being bombarded with whatever happens out there. Just sort of supporting them as well while the withdrawal symptoms, sort of a part of it is that people feel quite vulnerable emotionally and it's much harder to cope with everyday things, so they can focus on treatment. There is no visiting besides referrers can come and support with a brief visit, and clients cannot go and attend any appointments while they're in our treatment. It's just too much risk where in the middle of a peak withdrawal to go somewhere outside needing resources of 2 or 3 staff to go with. As I mentioned, the educational program is really looking at information about the various AOD services, health education, coping skills. Our psychology team is running sessions on coping with feeling or coping with stress, and staff is talking in groups with the clients about relapse prevention, setting goals, life after detox as such. Have listed a little bit of the agencies that do come in and talk about all the services and groups and programs they're running where clients could engage. As you see, we have self-help groups coming in as well, like NAAA or GROW. We have Wunjini, the Aboriginal Service, coming in talking about the Solid Grants program, which is really important because the only program where somebody could go Monday to Friday, like a drop-in, like a mental health day clinic for support instead of following up with a residential rehab service. If a client feels like they cannot go to rehab but need more support because they're not having work lined up or a lot of engagement and day structure. Now, where we're sitting as a detox unit is possibly a good thing to talk about because we're sort of sitting in between the outpatient withdrawal Craig commonly have spoken with the CATs are doing or the GPs are doing, and the hospital detox where clients are needing a detox, maybe attending for a medical condition and then have quite severe withdrawal. We're a community-based withdrawal, which means we have doctors and only after hours, over the phone available, so we have only Monday to Friday doctors on site. Our staffing level is as well for the 17 clients. We have one clinical nurse, a registered nurse, and an assistant in nursing on site, and that's all there is. There's no security. We have the security guard going around the building. That's all there is. Our clients need really to be self-caring, independent, and well enough because we're not set up. We don't have hospital beds to care for clients. We cannot do IV. We're not linked to a major hospital for support or follow-up or check-up. We need to transfer each client when they deteriorate to the ED department and then accept them back. Okay. Any particular questions to that? No. So what I said as well, priority groups are Aboriginal clients, pregnant clients, youth clients or rural clients. From the northern states, they can fly in by PATS. I don't know why, but Albany area or Southwest clients need to fund their journey by themselves. We certainly, the majority of our clients is alcohol, and given that alcohol withdrawal can be life-threatening, so a lot of our clients would have a history of seizures or significant withdrawals, have medical or mental health comorbidities that are stable, have tried before, maybe in outpatients or with the done referral in home setting, but hasn't been successful, or if they're not having enough support. I know that Craig, Dr. Rene has spoken already about how we sometimes have methadone to PUB transfer on the board when they are on a high dose of methadone, transferring to a PUB OST treatment. We sometimes do as well high-risk induction to the methadone, especially if the client is high benzodependent and it's too much risk to do that in community. We do at times as well benzostabilizations if clients are very chaotic and help the GP to set sort of a stable dose up or to start the reduction. You can see a little bit, that's the numbers from 2020. It's historically been around 65 to 70% of clients with alcohol that come for the peak withdrawal treatment with us for withdrawal. A bit of cannabis, quite a decline in amphetamine, that's possibly what's seen across the state, and a little bit of the opioid or coming off the methadone or PUB treatment. You see as well completed treatment is in the high 70s or in the 70s, which is sort of across AOD international as well for treatment outcome for a detox treatment. I want to show you a little bit as well where our referrals come from. So you see the 60%, that is sort of next step with their integrated service partners. We have about 26% coming from other AOD services like rehab services and other services that send referrals. And we have 6% of hospital referrals, and I will talk about that a little bit more. If we have empty beds, we send them out every day to the ED department so they know that they could send us referrals for acute alcohol withdrawal clients presenting to ED. So for elective admission, the referral will engage the client, talk with them about the best option for them as a treatment plan, because it's very important that there is a very good plan in place for after the detox, because the physical detox is only the start. The most challenges the client will face after is having cravings or being triggered by whatever alcohol or substances are around that they're struggling with, and or how they manage underlying issues or stressors or anything. So what we're asking is to start the relationship, build the rapport, start with planning, do some relapse prevention discussions, and then send us the referral when the client is ready. If a client wants to go to rehab, that's a time where the client will engage with the non-governmental rehab agencies, and then when the bed is there, they let us know, and we take the client in with a direct transfer date agreed, where the client goes from us on discharge date to the rehab directly. What I mentioned before, for us to be able to support the client, they need to be medically and mental health stable, because our team is not a mental health facility, our staff is not mental health or acute health trained anymore, so our focus is on the key withdrawal. We can manage like a comorbidity with the diabetes or hypertension or whatever it is, but the majority of those clients need to be in a stable health and physical as well as mental health level. Once the referrer has filled in the referral with the client together, which is a few release of information, privacy statement, and the contract, which is outlining to the client what our conditions are, what our rules are on the unit, and how we can keep it safe, they then fill in as well a drug and alcohol referral information assessment, and then comes to the CNS. Our CNS will then call up the client, check over a few critical issues, and then book the client in. And the importance is then that the client has afterwards that agreed support plan in place where they can get support and treatment. For the ED referrals, it's really that if we have empty beds, and we usually around nearly 90% bed occupancy, we send out that we have a bed, and then if there's a client in ED, they can refer to us, and if it's suitable, transfer to us on the same day for admission and continuation of the treatment. I believe that's it. Any questions?
Thank you.
Thank you.